consultant pediatrician at NMC Specialty Hospital, Dubai, and president of Dubai Pediatric Club. On behalf of all my colleagues in the organizing committee of Dubai Pediatric Club, I would like to welcome all of you from Dubai, UAE, GCC countries, all European countries, and all countries across the globe to this webinar. This webinar is conducted in collaboration with NMC Specialty Hospital, Al Nahda, Dubai, and is sponsored by Vita Biotics, New Country Health, UAE. I would like to thank the country business manager of this company, Dr. Tawfiq Ali, who is always helping us. And today's topic is fluid therapy stewardship. We have an eminent speaker, Professor MANU MALBRAIN, President of International Fluid Therapy Association, Medical University of Lublin, Poland. We have eminent panelists, well known to all of you, Professor Jayashri Muralidharan, consultant pediatric intensivist from Chandigarh, India, and Dr. Prashant Nath, senior intensivist, head of Department of Pediatrics, Critical Care Medicine at NMC Specialty Hospital. In a short while, I'll be introducing them. Well, we have eminent moderators, well known to all of you, Dr. Kalpana Sengupta, the secretary of the club, and Dr. Diari Muhammad, the chairman of the academic affairs. So, Professor Manu, Dr. Parshan, Dr. Jayashri, Dr. Kalpana, Dr. Diari, and myself. Well, is that moving? Yes. Well, as usual, this I have shown you before. Again, I would like to request the viewers to identify these two scientists, their contribution to the field of pediatric and pediatric intensive care. Just tell us who are these scientists and what are their contributions. The winner's name will be announced and Dr. Tawfiq will give a token of appreciation. Beautiful Dubai. I always say one of the most beautiful cities in the world. Those who have not seen, they can come and see. Beautiful city. Well, you see here the members of Dubai Pediatric Club from the first 2015 and second to 2009, and recently, few days back, we had our 10th annual conference. On behalf of all of them, I would like to welcome all viewers once again. Well, I would like to bring into your attention that the 10th annual Dubai Pediatric Club Symposium will be held on Friday, 22nd November 2024. The venue will be announced. It will be a physical in-person meeting. So detail will be announced. Well, here you see Dr. Tawfiq, our sponsor in the first annual conference, being facilitated by founder of Dubai Pediatric Club, Dr. Let Kuhi. And in 2024, he's being facilitated by Dr. Zakir, the medical director for Northern Emirates at NMC Specialty Hospital. So he's always helping us. Well, I would like to take this opportunity to tell our viewers about the World PICO Awareness Week. Next week is the World PICO Awareness Week. It's a 7-day event that culminates on May 13th, World PICO Awareness Day. It falls on the second Friday of May annually. We are fortunate enough just before that to have this webinar. The occurrence is organized by the World Federation of Pediatric Intensive and Critical Care to raise awareness about PICO in general, an important theme impacting the specialty. The theme last year was sepsis. So this year they will announce. Well, I would like to give very brief history of pediatric intensive care in just 5 minutes. You see this from the beginning. Well, my colleagues, they know I always start the memory of Hippocrates, the father of medicine. This is one of his quotations written on the wall of the emergency department in one of the medical schools in the United States. Life is short and the art long. The occasion instant. Experiment perilous. Decision difficult. Really, this itself defines the PICU. Well, I love this quotation by Isaac Newton. Whenever I get opportunity, I show him. Newton said, if I have seen farther, it is by standing on the shoulders of the giants. Who are the giants? In the field of fluid and electrolyte, they are the giants. Please remember, Sir William O. Shaughnessy, his medical research led to the development of intense intravenous therapy. Thomas Latta invented intravenous saline infusion in 1832, 200 years back. Today we are discussing about saline. 200 years back, Thomas Latta invented that. James Gamble, very famous professor of pediatrics at Harvard Medical School, Boston. He was a pioneer in salt and water disorders. Daniel Darrow, very famous for Darrow solution. He invented Darrow solution. Those who are working in this field, they know. And in the field of neonatology, Bent Fries Hansen, a Danish pioneer in neonatology and pioneer research in body composition. Those who have studied body composition in neonates, definitely they come across his name. So let us remember. And I would like to open a bracket here that all these were invented on the basis of cholera. Cholera killed many people, and all these solutions were made after cholera epidemics. Well, about the first pediatric ICU, the first pediatric ICU was established in Europe by Goran Haglund in 1955, means 70 years back, at Children's Hospital of Gothenburg, Sweden. So Sweden is pioneer in this field. Well, two people, scientists, we asked to identify. The first one is Dr. John Donis. He opened the first pediatric ICU in the United States at Children's Hospital of Philadelphia way back in 1967. Well, he is also known as Jack. Dr. Jack Donis, the anesthesiologist in chief at the Children's Hospital of Philadelphia, or CHOP. He was there from 1972 to 1996. And his achievement was before that. His defining moment was in January 1967, when the Children's Hospital of Philadelphia, CHOP, inaugurated pediatric intensive care unit, the first of its kind in North America. Well, with the growth of hospitals with PICUs in 80s, the American Academy of Pediatrics and the pediatric section of the Society of Critical Care Medicine set forth guidelines in 1993 for PICU. So this is my American Academy of Pediatrics. I'm not going to detail of the logo. Well, from 1930s to 1950s, adult respiratory intensive care units were created to battle the scourge of the polio epidemics with iron lung ventilator. These are the iron lung ventilators. You see, the history is very interesting. Well, the second gentleman is Mark Rogers. Dr. Mark Rogers, professor of anesthesiology, critical care medicine, and pediatrics at Johns Hopkins University, was the first doctor of his pediatric intensive care unit in 1977. He is the author of the first book. Regarding book and journal, Dr. Mark Rogers is credited with introducing the first comprehensive pediatric critical care textbook in 1987, called Textbook of Pediatric Intensive Care. This one. And in July 2000, the specialty's first and the only journal, Pediatric Critical Care Medicine, was established, just to remember. Well, now our heroes. I have seen the profile of our speaker, Professor MALBRAIN, and our moderators, Dr. Jayashri and Dr. Prashant, to all the groups. Well, our speaker is Professor MANU MALBRAIN, President of International Fluid Therapy Association at Medical University of Lublin, Poland. Our moderators, Dr. Jayashri Muralidharan, well known to all, consultant pediatric intensivist at Advanced Pediatric Center, Postgraduate Institute of Medical Education and Research, PGIMR, Chandigarh, India. And Dr. Prashant, senior intensivist and head of department critical care medicine at NMC Specialty Hospital, Al Nata. Of course, I would like to mention this here that today was the last day of Dr. Prashant present in NMC Al Nata. He is joining a big center in Europe. In the next meetings, we'll announce that. We are very happy. Of course, we are missing him. I'm chairing the session, and two moderators, Dr. Kalpana Sengupta, Senior Consultant Pediatrician, Head of the Department of Pediatrics at NMC Specialty Hospital, Dubai, Al Nata, and Secretary of the Dubai Pediatric Club, and Dr. Diari Muhammad, Senior Consultant Pediatric Surgeon at Al Jalila Children's Hospital, Dubai, and Chairman of the Academic Affairs of the Dubai Pediatric Club. Well, our speaker and panelists, well, I would like to draw the attention of our viewers that Professor Manu, along with Dr. Parshad, they have written this book, Rational Use of Intravenous Fluid in Critical Inpatient. Please note, this is freely downloadable. You can download it freely. I will show you the link so you can use. This is both our speaker and panelists. They are the editors of this. Well, the details of the profile of Dr. Manu I have circulated for the sake of the time. I'm not going to the details. Dr. Jayashri, very well known to all of you. Her profile also has been circulated. Well, as I mentioned, Professor Jayashri is a consultant pediatric intensivist at Advanced Pediatric Center, PGI Chandigarh. She has also edited this book along with Dr. Sonu Udani, Pediatric Intensive Care, and she was editor of the Intensivist, and many other publications. Is out of the scope of this webinar to mention that, very well known. And our next panelist, Dr. Prashant Nasa, I have sent also profile to all the groups. Well, as you see here, Dr. Prashant Nasa is also co-editor of this book, Rational Use of Intravenous Fluid in Critical Ill Patient. This is the link. We will put it in all groups again. This is a book you can freely download and read it. And here you see it was an opportunity to meet Professor Manu. And this is the typical gesture of international fluid therapy stewardship. Well, my references, beautiful Dubai day and night. I end here. I stop sharing. Now I would like to request Professor Manu to start the talk. I would like to request all viewers to write their question in a Q&A box. After Dr. Manu's presentation, we will have Q&A. Over to you, Professor Manu. Thank you.
Thank you so much, Dr. Sorab, for this very nice introduction. It's a real pleasure and an honor to be here tonight. Although I am a bit stressful because I'm not a pediatrician, but it's very interesting, and I think this makes the circle round again. My father used to be a pediatrician, so I'm very happy to be able to share some words of wisdom and knowledge with you on the framework of fluid stewardship. So let's kick off. If water is the problem and fluid accumulation is a problem, then de-resuscitation may be the solution. So these are my conflicts of interest. My biggest bias being the co-founder of the International Fluid Academy and a member of the medical advisory board of different companies. For my research, as stated, I'm affiliated to the Medical University of Lublin in Poland. So let's start with a short introduction. FAS, Fluid Accumulation Syndrome. It is a syndrome. It's not a disease, and as such, it can occur within many disease states and many conditions. But yet, most surgeons, anesthetists, and maybe also pediatricians do not care about perioperative or fluid accumulation syndrome in the ICU or pediatric ICU. Let's illustrate this with a typical patient admitted to the ICU after abdominal sepsis, perforated viscus. Blood pressure goes down and patient receives a bag of saline, then CVP is low, another bag, urine output is low, another bag, and at the end of the day, the patient may have received several bags of saline. Why is that? Because it's kind of a reflex. Whenever something goes wrong in the ICU, we want to give some fluids. So on postoperative day 2, we see that the abdomen is distended and the creatinine has increased. Then by day 4, patient doesn't pass much urine. There's a positive cumulative fluid balance above 7 liters, so the patient has fluid overload, and a further increase in creatinine and CVVH is started. On day 7, sudden call in the ICU, cardiac arrest because of acute mesenteric ischemia and abdominal compartment syndrome, probably related also to fluid overload and accumulation. Intra-abdominal pressure kills. But did you do everything to prevent fluid accumulation syndrome? And are you already thinking fluid stewardship? So the lecture today will be also about breaking some bad habits when it comes to the type of fluid, dose, duration, and de-escalation. So let's go back a little bit back in time, and this is 2011 when the International Fluid Academy was founded. We were 5 colleagues, Niels and myself from Belgium, Paul Elbers from Holland, Xavier Monet from France, and Adrian Wong from UK. And the mission of the Fluid Academy is to foster education, to promote research by collaboration between healthcare providers from all disciplines. The other reason why we started this was that during my years of medical training, I exactly received 0 hours of education on fluid management. In fact, 1 in 5 patients may suffer from complications of inappropriate fluid administration. And this can be either too much fluid or too little fluid. And that's why we should look at fluids as any other drug or medication like antibiotics. It's about the drug, the dose, duration, and de-escalation. So together with Prajant, we also conducted an international survey on the knowledge of fluids and fluid management. We received information of over 1,000 healthcare providers, and the results were devastating. The average score was 46%. So we did not pass the test. Again, when we are doing the Fluid Academy meetings and we ask questions like, what is the best maintenance solution in adults, at least, it should be a hypotonic balanced solution. Whereas the majority of delegates still thinks that isotonic solutions or even saline is the best option. We are humans. Humans do make mistakes. To err is human. But let's forget about the mistakes and remember the lessons. So to help you breaking some bad habits with the Fluid Academy, we publish reviews, guidelines, and we conduct research on fluid stewardship, executive summaries after fluid meetings, book chapters, fluids in COVID patients, a little bit on salt accumulation that may even be more important than fluid accumulation. So we need to look at sodium. And this was a recent review of fluids in patients with abdominal hypertension, one of my other favorites. And the last publication was a multidisciplinary expert panel report. And I will get back to this one at the end of my talk. As Dr. Sarab alluded to, we recently, I think it was the end of December, launched a book on rational use of intravenous fluids, and it's available under the open access. I just checked, and it has already been accessed and downloaded over 622,000 times. So this tells me that when it's for free, people like it, but also it tells me that there is still a gap that needs to be filled when it comes to knowledge about fluid therapy in critically ill patients, also children. With the Fluid Academy, we started traveling around the world and creating pop-up meetings like we had in Amsterdam in 2018. We went to Mexico in 2019, Valencia, Spain, also 2019, Sao Paulo, Brazil, where we had Flavio Nacul, Fernando Zampieri, who is the lead author of the Basics trial, as well as Anders Perner from the Classic trial. We also went to Campinas in Brazil. In the last year after COVID, we started again, and this was in Palembang in Sumatra. And then we stopped in Jakarta, in Java, as well as in Bali, Indonesia. And then this year we were at Dubai at the UAE critical care meeting, as well as we saw the more funny picture, but this is the serious one, when I was invited to Prajance Hospital in Dubai. And after that, we also had IFAD meetings in Abu Dhabi, Kuwait City, and recently in Manila in the Philippines. So I'm very happy that people have an increased interest to understand more about fluid therapy, and that we can do this IFAD mini pop-up meetings around the globe. And next week, I think, no, this week, on Friday, we will have an IFAD mini again in Dubai during ECCC meeting. So let me introduce you to the the 10D framework of fluid stewardship. D1 being definitions. D2 being diagnosis of hypovolemia fluid responsiveness. D3 is on distribution of fluids. What happens to the fluid after administration? D4 is drug, fluids or medicines. D5, dose. D6, duration of treatment. We should stop it when no longer needed. D7 is on de-escalation. D8, documentation. It's important that we document what we are doing at the bedside. And I've added D9, which is diligence, which is careful management, and this can be summarized by fluid stewardship as well, while D10 is discussion, and the discussion should go about leadership, because implementation of fluid stewardship is about change management. So when we have D1 to D10, we multiply, we have D to the power of 10, and this is what I should call fluid stewardship. This is what you and I should be doing in the ICU, in the PICU, in the hospital. So let's start with D1 on definitions. Fluid balance is what is calculated every day by the nurses on a daily basis, or you can look at cumulative fluid balance over a period of time. Fluid overload in the initial literature is defined by the cumulative fluid balance, or the actual body weight divided by the baseline body weight. And a cutoff of 10% would then identify a patient with fluid overload. Early adequate goal-directed fluid management, Dr. Sarab alluded to the blue stage of spasmodic cholera, where patients are profoundly hypovolemic. There is place for goal-directed treatment, and like we know from the surviving sepsis guidelines, the 30 ml per kg. Late conservative fluid management was introduced by Murphy as 2 consecutive days of a negative fluid balance within the first week of ICU stay, and late goal-directed fluid removal is what I would like to call de-resuscitation or active removal of excess fluids with diuretics or CVVH and ultrafiltration. So when there is fluid overload, this will lead to hypervolemia, hyperhydration, and peripheral edema. Hypervolemia will always be associated with peripheral edema just because of hydrostatic forces, while the opposite is not always true. It's not because you're edematous that you're also hypervolemic. That's why Jean-Louis Vincent suggested maybe we should avoid the term fluid overload, and everything you need to know about de-resuscitation is again available in another open access paper published in Intensive Care Medicine. And there we introduce the term fluid accumulation, which can be calculated as an increase in body weight, either relative or absolute, or an increase in cumulative fluid balance in relation to baseline body weight. Maybe the presence of peripheral edema, or calculation of circulating blood volume, or calculation of volume excess with bioelectrical impedance analysis could be helpful. We must understand that most of the fluid is intracellular, while 1/3 extracellular, and out of that 1/4 intravascular. When we talk about fluid accumulation, we mainly mean the increase in extracellular water or interstitial fluids. But when we talk about hypervolemia, we mean an increase in intravascular fluids. So fluid accumulation syndrome can then be defined as the presence of any degree percentage of fluid accumulation with a negative impact on end organ function that is newly present, or can be associated with a global increased permeability syndrome. So there are many more definitions. I'm not going into detail here, but it's important that we use proper definitions, and this is also the first chapter in the book where we have a full list of these definitions. So let's move on to D2, which is about diagnosis. We know that hypovolemia is bad, but hypervolemia may also be detrimental. That's why the prediction of fluid responsiveness, and this is again a recent opinion piece in Intensive Care Medicine, written with Xavier and Michael, where we give an overview of the different fluid responsive tests like passive leg raise, pulse pressure variation, vena cava collapsibility, and expiratory occlusion, or tidal volume challenge, as Sheila Miatra recently published. Fluid responsiveness can or cannot be accompanied with a preload that is either very low or very high. At the other end, fluid overload accumulation can or cannot be accompanied by a very high amount or little amount of peripheral edema, or this global increased permeability syndrome. In between, there is a new concept which is defined as fluid tolerance, which is the maximum amount of fluids that we can give to a patient without causing harm. So when a patient becomes fluid unresponsive and there is venous congestion, think about abdominal hypertension, then he may be fluid intolerant. And the balance between fluid responsiveness and fluid tolerance or venous congestion may determine the risk of fluid accumulation syndrome. And this may be variable over time. Just to show you, a recent paper by the group of Philip Rolla showed that if you look at patients who have venous congestion signals, and you look at the ones who are fluid responsive or fluid unresponsive, then you can see that also the fluid responsive ones can have VEXUS grade 1 or grade 2. So it's not because you are fluid responsive that it means that you're hypovolemic and you can't have venous congestion. So there is an overlap between these conditions. That's why the fluid status is important. It matters, but there are many myths and misunderstandings. Like, not all septic patients are truly hypovolemic. I told you that peripheral edema does not mean that we need to give diuretics. And it's not just because you're fluid responsive that we need to give fluids. There is also some misconception between stressed and unstressed volumes. And in this video, I think it's from Ashley Miller, I found that it nicely illustrates the way how noradrenaline vasoconstriction recruits stressed volume from the unstressed and increases venous return. By squeezing the unstressed, you recruit stressed volume. And remember that septic patients at the very beginning are vasoplegic, not necessarily hypovolemic. So it's important to understand macro hemodynamics, the pump, cardiac output, mean arterial blood pressure, with a waterfall system where we have at the venous side central venous pressure, mean systemic filling pressure, and at the level of the arterial line, there is the pulse pressure, also the perfusion pressure. So pulse pressure at the level of the end organs may be limited. Preload is important, afterload, as well as contractility. So at the level of the kidneys, perfusion pressure is important, which is not only the arterial inflow, but also the back pressure at the venous side. And when there is a condition of increased intra-abdominal pressure, this will reduce perfusion pressure and will increase organ damage and failure. So let's move on to D3, which is about distribution of fluids. As said, the fluid status is important, and we must understand basic principles like osmolality versus tonicity, whereas the osmolality will determine the tolerability, and the tonicity is the effective osmolality, mainly determined by the sodium levels, and this will determine the distribution of the administered fluid. I told you that most of the body is water, like 2/3, out of which 2/3 are intracellular and 1/3 extracellular, out of which 1/4 constitutes the intravascular fluid, whereas the rest is the interstitial fluids. So what happens if I would administer 1 bag of saline, called normal saline, 0.9, which is an isotonic solution, and I go back and look after 1 hour? Only 250 cc will be in the intravascular space. If I would give a hypotonic solution like glucose or dextrose, most of it will go to the intracellular space, so it's very good for cellular dehydration, and only 83 ml will remain intravascular. And from colloids like albumin, if you would administer it and look back after 1 hour, this would remain 100% intravascular. We think about albumin could be about 6 hours. So D4 brings me to drug. Fluids are drugs. Of course, we shouldn't harm our patient. And we have to ask ourselves 4 questions. When to start giving fluids? When to stop fluids? The best fluid may be the one that has not been given unnecessary. Some points, patient may accumulate fluids and we may need to start fluid removal. And if you're removing fluids, at some point we must stop fluid removal. There are only 4 indications to administer fluids. One is for resuscitation, to save lives, like stated in the guidelines. Second indication is routine maintenance, to cover the daily needs of water, glucose, electrolytes. Third is replacement, that should mimic the fluid that is lost, and maybe this is the only indication for saline. Fourth indication is to re-energize nutrition fluids to cover the daily caloric needs. But a fifth is not an indication, but those are fluids that seep into the patient unnoticed, is to dissolve other drugs. If you want to administer antibiotics, painkillers, antacids, these are usually dissolved in saline. And then we must remember that all fluids are redistributed, so we have to reassess volemia status and fluid responsiveness. So these are the 7 R's. And my colleague Niels van Regenmotor looked at it in 15,000 ICU patients, and we found that only 3% of all fluids or blood products, 6% only for resuscitation, 22 maintenance, 3% replacement, nutrition 33, and then another 33 was fluid creep. So 66% is nutrition or fluid creep. And if you take into account routine maintenance that may not be needed, is a lot of fluid that go into a patient unnecessary, maybe. 10 years ago, there were the big fluid trials and debates between colloids, crystalloids. You remember the CHESS trial, the SUCCESS trial. And more recently, there was the debate between saline versus balanced solutions. And we had the split trial, the SMART, the SALT, the basics, and the plus trial. So all these big fluid trials up to 1 or 2 years ago created a lot of commotion, reactions within the scientific community. And it all comes down to the difference between a balanced solution versus saline. Saline has a strong ion difference, so the strong cations minus anions of 0, and it will hence reduce pH, so it will induce hyperchloremic metabolic acidosis, whereas a balanced or buffered solution has a strong ion difference above 26 milliequivalents. So recently, there was a systematic review and meta-analysis looking at all these trials. And if you pull them, especially in septic patients, there was balanced crystalloids were preferred, but not in traumatic brain injury, where saline is still the first choice. And if we look at a postdoc analysis of the SMART study, where they compared the impact of balanced solutions versus saline on chloride levels, if you look only at the ICU trajectory, is not much difference. But if you combine ER and ICU, you see that saline results in hyperchloremia and saline results in higher hospital mortality. A postdoc secondary analysis of the BASICS trial looked at patients who received balanced solutions only, and those had a better, higher probability that balanced solutions would decrease mortality. So balanced only during the whole stay, so before and of course after the randomization. So if we pool these trials, and this sums up to 34,000 patients, we can conclude with 90% probability that there is a 1% reduction in mortality. And it goes from -9 to +1%. Balanced solutions are associated with less major adverse kidney events. And if you combine the trajectory within the ER and ICU, there's even a greater impact, especially in sepsis, burns, DKA, but not in TBI. So there, saline seems to be a first choice. There were also recent guidelines in pediatric patients from ESPNIC, systematic review and meta-analysis. And the bottom line, if you look at the PICO2, do isotonic solutions versus hypotonic as maintenance solutions have an impact? And in children, it's found that hypotonic solutions decrease sodium, but balanced solution seem to have significant decrease in mortality. So it seems that isotonic balanced solution, not saline, should be the ideal solution. And this was confirmed this year, meta-analysis in pediatric nephrology, where again the same bottom line. So isotonic fluid decreased risk for hyponatremia, but balanced solutions were superior than saline solutions. So it's the same result of these recent meta-analysis, and maybe we can conclude that there is nothing normal about normal saline, and we should call it maybe abnormal saline, or just call it saline. Why? Well, it contains 3.5 grams sodium, free sodium, where we only have a daily need of 2.3 for adults, of course. So if we sum up all the potential deleterious effects of saline, it's a lot. And mainly it causes hyperchloremic metabolic acidosis, increase in sodium chloride, but also potassium levels, especially in patients with AKI, increase in vasopressor need, AKI and renal replacement need. And because of the sodium retention, there is also positive fluid balance and fluid accumulation. So what is then the ideal solution? I don't know the answer, but what comes closest is what has been proposed as hemofiltration substitution fluids. And the ideal solution should have a strong ion difference above 26, so maybe around 28, but you see then there is a little bit of alkalosis. I believe in the future the discussion may no longer go between saline or balance, but maybe about the type of buffer, and there are many types. There is a misconception that people think that these are bicarbonate precursors, but their role is not to generate bicarbonate, but to disappear rapidly as soon as possible to increase the strong ion difference and thereby have a beneficial effect on acid base. So let's move on to D5, which is the dose. And Paracelsus nicely stated that everything is poisonous. You can kill someone just by an overdose of water drinking and poisoning. Together with Niels, we performed studies looking at sodium in sodium intake, so saline versus hypertonic solutions as maintenance in healthy volunteers and in critically ill patients. So above you see the healthy volunteers, left in red saline, so in blue hypertonic balance solutions, and these were basically the nurses of the ICU that were locked up in a very nice hotel, but they only received an infusion to cover the daily needs. And after 2 days of maintenance with saline solutions, they had a positive sodium balance of plus 150 millimoles. And the ICU patients had plus 300 millimole. I mentioned on a previous slide that the daily needs is only 1 millimole per kg. So this is a lot of sodium, a lot of salt. And this resulted after 2 days in a positive fluid balance in healthy volunteers, plus 600, and in ICU patient, almost 1 liter more positive because of the saline overload and the fluid accumulation. But that's why in Belgium we don't have too much wine. We're starting some wine, but mostly we have beer. And when you have the beer, it always comes with salty peanuts. So the salty peanuts increase the salt, make you more thirsty, so you drink more and you will pee less, you will accumulate the fluid, so you sit on the bar. It's a win-win for the bartender. When it comes to the dose, we know very well the key concept of pharmacokinetics and pharmacodynamics when we talk about antibiotics. And the same holds true when we look at fluids. So the pharmacokinetics can determine is what we give fluids to avoid fluid overload, and the pharmacodynamics is that we give fluids to treat shock. So giving fluids to treat shock, but as a potential side effect when you give too much to cause fluid accumulation syndrome. We must be aware that as long as you are infusing fluids, there will be a volume expansion effect, and excretion is low in critically ill patients as compared to healthy volunteers, unless you're giving too much salt, and distribution is also slow down in patients with hypovolemic shock. So the bottom line is that there is not much difference between crystalloids or colloids as long as you're infusing and if the patient is in a profound state of shock. D6 is about duration. We should not use fluids to treat the numbers, like in the case I presented, not because blood pressure is low, CVP urine output, but to treat shock due to VO2 imbalance and lactate increase. D7 is about de-escalation. And here I would like to introduce the ROSE concept with the 4 phases of fluid therapy: resuscitation, optimization, stabilization, and evacuation. So it's like giving water to a rose, blossoming and drying at the end. So after the first hit, whether it's sepsis, burns, trauma, pancreatitis, we need to give fluids fluids are life-saving. Then comes the second hit. And the second hit is ischemia and reperfusion. And fluids accumulation is like a biomarker for critical illness. The more fluids you accumulate, the sicker you are. And then we must aim for a zero fluid balance and support organs. Then the third hit is what I would call global increased permeability syndrome. Patient keeps on having a positive cumulative fluid balance, and there we must evacuate. Either the patient does it spontaneously, as you see after tubular necrosis, or with diuretics. And the fourth hit, we must avoid hypoperfusion, hence the ROSE acronym. And just like the blossoming of the rose at the end is just a dry one. It's not a dead liver or a dead patient. I'm very happy to see that the rose concept has been picked up by other colleagues like in neurocritical care. And again, in the open access paper on everything you need to know about deresuscitation, we elaborate a little bit further on the ROSE model, escalation, de-escalation, the ebb and the flow phase of shock. And to summarize, we need to rescue the patient with goal-directed therapy, anything you choose, to optimize organ function. Then we install late conservative fluid management. We stabilize the organs. And then sometimes you may need late goal-directed fluid removal to evacuate the excessive fluid and save the patient. So initially, we target fluids based on macro hemodynamics, also lactate and so forth, maybe passive leg raise, functional hemodynamics, volumetric preload. When these normalize, when the patient is no longer fluid responsive, then we stop, maintain zero fluid balance, and fluid deresuscitation should be done when there is a negative impact of fluid accumulation. So you need to have any percentage of fluid accumulation with increased lung water. You can have Vexus grading with point of care ultrasound, low PPV, negative passive leg raise, increased intra-abdominal pressure, and so forth. And then when you're evacuating, we have to check perfusion. The problem is there is no one single study covering all these phases. So mainly some of the studies focused on the very early phase, some on deresuscitation. So in the paper, we give some guidance on the 4 questions. So when to start fluids when the patient is in shock, of course. When to stop fluids when the patient becomes unresponsive. When to start fluid removal when there is fluid accumulation syndrome or GIPS, global increased permeability syndrome. And to stop fluid removal when again there is hypoperfusion. I have to say there is no one single study, but at least this gives you some guidance and some triggers, targets, and safety limits. It's important to set these right to reach our goal, which is to avoid global increased permeability syndrome. And a global increased permeability syndrome is a persistent positive cumulative fluid balance. So the patient has a positive fluid balance, swollen up, there is capillary leak, and new organ failure and dysfunction. So one of my favorites is that the intestines will swell, there will be ileus, and abdominal pressure will be increased. Problem is that a positive fluid balance is an independent predictor of poor outcome. And some recent trials showed that restrictive fluid therapy is beneficial, although later on the big trials like Clovers and Classic could not confirm this. But yet when we're resuscitating fluids and there is sepsis, there will be total body fluid, second, third space accumulation, increase in intra-abdominal pressure, bowel edema, compression of the vena cava, then a reduced blood flow to the heart, reduced cardiac output, reduced blood flow to the other organs, and this may trigger a multi-system organ dysfunction failure vicious cycle. I'm an internal medicine physician, so I got interested by fluid accumulation syndrome because it really has an impact on every organ system, not only within the abdomen, but far outside. And the edema you see at the outside, the anasarca, just mirrors the edema that will be happening at each and every organ system. This will lead to venous hypertension and venous congestion. And this is what I would call this global increased permeability syndrome. So therefore, anasarca, peripheral edema, is not cosmetic, it is bad medicine. Or it may be a sign of poor source control that you need to do better. D8 is on documentation. Let's have a look what is the knowledge of doctors in UK, and this was published by Johnny Wilkinson, where they performed a medical audit, and internal medicine physicians provided nine times too much salt to their patient, whereas they were given too little potassium, not covering the daily needs. This you probably know is the Little Mermaid in Copenhagen, where lives Anders Perner, the leading author of the classic trial and other major studies. And they looked at isotonic solution issuing in Danish hospitals. What they found is astonishing. Of all solutions, almost 70% is abnormal saline. We know now it's abnormal, and about 2 liters per patient. And this was so in all departments. It was a bit better in ICU and OR. This you probably don't know. I didn't know either, but this is Beautiful 5, which is in Scotland. And in Scotland lives Marsha McDougall, who was the first to introduce the NICE guidelines of fluids stewardship. And when they started off already more than 10 years ago, they saw a drop in the use of saline, a drop in the use of Hartmann because they replaced it with Plasmalite, balanced isotonic solution, and they used a hypotonic balanced maintenance solution, glucose 4% and sodium 0.18% with potassium. By doing so, they reduced the liters per day, and this resulted in a benefit of over 80,000 British pounds per year, and a reduction of 5 liters per patient to now I think there are already around 3 liters per patient, by starting much more rapid with oral feeds, switching intravenous medicine to oral medication, and so forth. So, ladies and gentlemen, the clock is ticking, and I think we can do better. We must do better, and brings me to D9, which is diligence, which is careful acting for our patients. And what we should be doing is introducing fluid stewardship, which can be defined as a series of coordinated interventions introduced to select the optimal fluid dose duration of therapy that results in the best clinical outcome, prevention of adverse events, and cost reduction. And this is summarized in this open access paper on fluid stewardship that already has been downloaded a lot, almost 250,000 times, and it's still #1 of all times of the journal Annals of Intensive Care. So it's freely accessible. Brings me to the last D, which is about discussion, and this is about leadership and change management. And this is summarized in a recent review paper, a multidisciplinary report, where we help hospitals to start and implement fluid stewardship by identifying the clinical leads, establishing a core fluid team, do the knowledge test amongst doctors and nurses, then plan for your strategy, and then prepare for the implementation of fluid stewardship in your hospital and ICU. So to wrap things up, ladies and gentlemen, I hope I convinced you that IV fluids are not just innocent bags of water. No, they are not. They are drugs, they are medications. They come with indications, contraindications, and potential adverse events, and they may be a double-edged sword. So when it comes to fluids in sepsis and ICU, also pediatric ICU, we don't use starches, gelatins, saline in large amounts, or hypotonic solutions unless needed. For resuscitation, I think also in children, isotonic balanced solutions are a first choice. Saline should be preserved for traumatic brain injury, or when there are a lot of saline losses, or when the patient becomes metabolic alkalotic, when there are gastrointestinal losses. For maintenance, we should avoid fluid creep, remember, and for adults, hypotonic balanced, but I think for children, the systematic review showed that isotonic balanced solutions, but not saline, should be the first choice. Albumin definitely may also have a place in children, and we'll await the Albius 2 trial to see how it could be used in severe septic shock. But remember that the fluid strategy is more important than the fluid itself, and also in DKA, AKI. So I hope you appreciate it. This was a previous version where I had the 7 Ds, but now we talk about the 10 Ds. Remember the 4 Ds, drug dose, duration, de-escalation, and the 7 Rs of fluid management. You need to set up your fluid team and start with individualized, better personalized fluid therapy. You need to identify nurses, doctors who will become your fluid stewards and lead the change. Having said that, I also invite you to join the International Fluid Academy with a lifelong free membership. Thank you for your attention.
Thank you very much, Professor Manu, for this excellent illustrative presentation of the facts about the fluid stewardship. I'm sure everybody has enjoyed. We learned a lot. Now I would like to request our panelists, Professor Jayashri, Dr. Parshant, Dr. Kalpana, and Dr. Diari to join us in the panel. And I would like to request the viewers to write the question in Q&A box. I would like to request Dr. Kalpana Singh Gupta, Secretary of the club, to start the discussion, please.
Thank you, Dr. Saurabh. Thank you, Dr. Manu, for this interesting lecture. And I would like to start by asking Dr. Jayashri, who's our pediatric intensivist expert here, straight up, what do you think about this whole lecture's applicability as far as pediatrics is concerned? So are we facing a similar problem? Are we along the same lines? What are your initial thoughts, Dr. Jayashri?
Thank you, Dr. Kalpana. Thank you, Dr. MALBRAIN, for that elegant talk. It's really, it was so comprehensive and so lucid. Thank you very much for taking us through the 10 Ds of fluid stewardship. I remember I read your paper in which you stressed on 4 Ds, but I really like the fact that you have now expanded the Ds to the 10, almost like a 10 commandment it has become. So it's really good. Yeah. So I think the pediatric aspect is pretty similar. We do have a lot of problem with hospital-acquired hyponatremia, and we do have problems with hyperchloremic normal anion gap metabolic acidosis with the use of a lot of saline, acute kidney injury. So we have done few studies, single center, of course, on DK, in which we have looked at saline versus plasmalite, which is the SPINK trial, which was published in 2020. Because children with DK in our setup, they tend to present very late and already have pre-renal AKI. So using saline, which has a strong ion gap, as you said, this strong ion difference, sometimes becomes difficult because it masks the resolution of DK and also puts them at higher risk for getting onto progressive AKI. But when we compared plasmalite with saline, since it was a single center study, we didn't find much difference. We found that plasmalite was quite similar to saline. And we have done another single center, which is due for publication, where we looked at lactated ringers. Now here I have a question for you, Dr. MALBRAIN. The ringers lactate or Hartmann solution, it's balanced in terms of chloride and the ions, the acetate ion which is there, but the sodium content is far lower than saline. So there are some concerns that it might induce hyponatremia in critically ill patients. So, but I saw some of the studies where you showed that saline actually causes more of sodium overload. So what is your take on ringers lactate as compared to saline in relation to the sodium specifically?
Is a very good point, and I think in children there is always this concern of hyponatremia and disorders and neurologic complications. So you're fully right that Ringer's Hartmann is a bit hypotonic solution. So I'm not a big fan of it. Also not in adults. If you need to give vast amounts for resuscitation, as there the best is isotonic, which is either saline or plasmalite, who also has a higher sodium content above 140. So it's more isotonic than the Ringer. So for adults, definitely and this is the result of the systematic review. There is now a tendency that we give balanced solution, and most of the study was done with the plasma light, so it's more that we choose for plasma light. I understand in some low middle income countries in adult ICU is very expensive. Plasma light may be 3 times more expensive as compared to saline or ringer. So if this is an issue, then it's still better to provide ringer or Hartmann in adults as opposed to saline, because the big problem to me is even more than fluid accumulation is sodium accumulation, because sodium accumulation, even for healthy kidneys, takes a lot of time to get rid of the patient. You've seen in healthy nurses, when they get saline as maintenance compared to hypotonic balanced, they end up with a positive fluid balance of 600 cc after 2 days. Of course, they are healthy and they will pee it out and everything is fine. But in critically ill patients, this may be detrimental for end organ perfusion because of increased back pressures, venous congestion, and so forth. So we are planning a big study, which is called the Crusaders trial, where we will randomize between saline versus no saline, but also for dilution and dissolving drugs, and so for everything, for maintenance, for resuscitation, as well as for most of the drugs that can also be diluted in glucose rather than saline. But sorry for the long answer, but fully agree that ringer is a little bit hypotonic, and in children this may also have concerns.
Thank you very much. Over to you, Dr. Kalpana.
So again, back to Dr. Jayashree, like Dr. Manu showed about the sodium overload that happens with the choice of solutions in adult ICUs, do we see a similar situations happening where we are giving them much more sodium than they need and much less potassium, as he showed?
So, so in critically ill, where we use isotonic saline as resuscitation followed by maintenance, we have in fact not seen much of hypernatremia. I mean, clinically symptomatic or clinically significant hypernatremia in these children. So theoretically, there is a possibility. I mean, Dr. MALBRAIN can correct me, but I think there is a secondary desalination which occurs, especially if the kidneys are functioning fine. I think it helps in keeping the sodium possibly within the range. So in sick children, we have not seen or encountered any hypernatremia when we use isotonic saline. It may be seen in a very minuscule proportion, but not a significant problem. So, so am I right when I say, Dr. Manu, that if we load with more sodium and if the kidneys are fine, there will be some amount of secondary desalination, or that concept no longer holds?
I'm sorry, did not understand. There will be second.
I mean, the kidneys will, throw out the excess sodium or try to maintain the sodium balance if the kidneys are functioning fine.
Yes, they will, but it takes time, and the sodium per se may also induce AKI and diminished perfusion to the kidneys. There are many studies showing that there is an increase in NGAL, cystatin C. There is also an increased need for vasopressors, increased need for renal replacement therapy. I'm speaking about adult mainly, but I'm sure, and the recent meta-analysis in children showed that the isotonic saline has a statistic increase in hypernatremia. So maybe it's not that straightforward. Prashant?
So, Dr. Kalpana, there is a question from Dr. Ahmed Al-Masri asking about how you overcome the hypernatremia, now especially if the kidney is impaired.
That's a question for who?
For you. For you.
Me. Okay.
For you.
I think it's yeah, I see the question. It's during de-resuscitation, because of course then you can have an issue that the sodium may increase. That's why, and usually when you start with diuretics, when we do it, we use the PAL treatment. So usually there is increased lung water and pulmonary edema. So we recruit it with the high PEEP set to the level of the intra-abdominal pressure. Then we give the hypertonic albumin. We wait 30 minutes, and then you start the furosemide bolus, furosemide stress test, and a drip. But you will see that only 1 day or 2 days you get a negative fluid balance, and then the sodium increases, and the patient is no longer responding. Then we soonly will start over to CVVH and ultrafiltration, because then you have metabolic control and your sodium will be normal. If you want to continue with diuretics, you can check for a combination treatment. So acetazolamide first, if there is some alkalosis maybe, and then the furosemide, maybe some indapamide if there is increase in sodium. So a cocktail of diuretics has also been suggested.
Dr. Prashant Dr. Prashant, I would like to request you also give your comments.
No, thanks, Dr. Sorab. I completely agree with Professor MANU MALBRAIN, when he was pointing out about hypernatremia and the challenges which we face. Again, my disclaimer stays the same. I'm an adult intensivist, so my experience will be primarily coming from adult ICU. But yes, the important challenges which we understand is about hypernatremia while treating these patients with 0.9% saline or so-called abnormal saline is primarily seen in neonates, where already, the glomerular filtration is a challenge. Even the latest meta-analysis, which was published this year by Egyptian group, Amir et al., they also found that neonates were much more prone to get hypernatremia and metabolic acidosis. But yes, it's like, as Professor Manu always say, that we are very good in killing up the patients. It's the patient who survive most of the time when you are doing that. So understanding these challenges, we need to balance out the fluids. We need not to be very much pro in one direction. Not every patient will have a osmotic, non-osmotic stimuli of ADH secretion. You need to balance it out with looking at daily fluid, electrolytes, and sodium balance, which need to be done. And the moment we see that, patients are turning on the other side, that's the time to consider 0.9% solution, 0.9% saline to be stopped completely. In fact, the recommendations is only for isotonic solutions, and 0.9% saline is definitely not an isotonic, as Professor MALBRAIN pointed out in his talk also.
Sorry, I'm interrupting. Dr. Prashant, there was one study on 5,000 children regarding the saline. Can you tell about that?
Okay, I think this is latest meta-analysis which was published by Amir et al. This year. This include almost all randomized control trial published so far comparing isotonic solutions to hypertonic solution as a maintenance fluid in critically ill children. But they found, but for the first time they did a subgroup analysis by comparing less than 24 hours and more than 24 hours just to understand whether long duration of infusion of isotonic fluids will have a different outcome versus short duration. They were couple of things which were little surprising in the meta-analysis, though did not explain. Those things were, yes, when you give longer duration of isotonic fluids, the chances of getting a hypernatremia is high, while when you give it for shorter duration, it doesn't. So that's why the hypertonic fluids is okay. It means it was 0.9% where the risk is hypernatremia. But what was also important was when you give it for less than 24 hours, it doesn't matter at all whether you give isotonic or you give hypertonic. So it's the longer duration which is important. But the patients who were not getting hypernatremia is also because the patients of this so-called osmotic stimuli is for very short duration, and also very few patients. As soon as the patients are getting critically ill from a critically ill state to a normal state, this stimuli will go on, and the patient may start developing hypernatremia. So we need to be monitoring the fluid balance. We need to be monitoring the sodium balance and glucose balance on a daily basis, rather than just empirically continuing with 0.9% saline in these patients. It's good in a critically ill patient as a maintenance fluid to start with if you do not have isotonic fluid in your ICU, and that's what they found out. But the important part is you need to consider daily monitoring of electrolytes, water, glucose, and as soon as you see the patient is going into the other state, that's the time to stop giving any more hypertonic fluids. In fact, consider oral fluid as early as possible in these patients.
Thank you.
I think Professor Manu wants to add something.
First, I fully agree with Prashant. I just would to make sure that there is no misunderstanding and confusion in the fact that maintenance solutions are only needed when the patient cannot have any normal oral intake, or when it's forbidden, or when during major surgery. Most of the time, I think it's an ugly fluid and we don't need it because the patient gets already many other sources, either from nutrition, either from drug dilution. If you count all this up, you may end up with an amount of fluid that covers the daily need. And also, we talk about saline and maintenance. Saline can never be a maintenance solution, but I suppose that you mean dextrose in saline or something, because it needs also to have the glucose. I just wanted to say that maintenance, most of the time, is not needed because there is enough fluid creep. That would be my major message. And another thing I saw in the questions is regarding ringers or a balanced solution that contains potassium in a patient with AKI and already an increased potassium, because there is the fear that the extra added potassium will further increase. But this is a misconception. Saline will increase potassium even more because of the acidosis and the potassium shift. So it's perfectly safe to give ringer, Hartmann, Plasmalite, even if the potassium is increased.
Dr. Girish would like to know, once the resuscitation phase is over, what is the kind of fluid would you use in maintenance, as maintenance in your ICUs? So, Dr. Jayashree, maybe you could take this one.
So once the resuscitation is over, so whatever rehydration followed by maintenance is usually done in our ICU with isotonic saline. We haven't started using balanced fluids as maintenance fluids in our ICU. So the only balanced fluid that's readily available for us is the lactated ringers, or what is called as the Hartmann solution. The Plasmalite is about 4 times more expensive than saline or the lactated ringers. So it becomes a little bit of issue for us, especially in low middle income countries. So we generally use the isotonic fluids, or in some patients, we sometimes go for half normal saline with dextrose, or normal saline with dextrose is what we use generally. And if we feel that the chloride is high and there is a risk for acute kidney injury, in those children, then we go for balanced fluids. And among the balanced fluids, the easily available one is the Ringer's lactate. So that's how we usually decide. So this is after the resuscitation. What I'm saying is after the resuscitation.
And Dr. Nayan Shetty, who's a pediatric intensivist, his comment is, due to many reports of hyponatremia secondary to 0.18% saline, this fluid has been replaced in the UK. Would you reinstate this as the preferred maintenance fluid rather than Plasmalite?
Is a question for me, or well, in this solution of 0.18 saline in dextrose 4% plus some potassium and electrolytes has been suggested in the NICE guidelines in the UK. We never used it in Europe, so we have already from the shelf balanced hypotonic maintenance solution, which is called Glucion. And I think there are other commercially available solutions like Maintalite, but this again is for adults. So those are hypotonic and balanced for maintenance if needed. In children, I'm not sure whether there are this kind of balanced isotonic solutions, because what you also have is Plasmalite in glucose. It also exists, and maybe this in children could be a better maintenance solution if you're afraid for hyponatremia.
There's a question from Dr. Muhammad. It's for you, Dr. Manu. You mentioned that the balanced isotonic solutions are preferred. do you suggest to also reduce the rate of infusion to 2/3 of the calculated conventional maintenance volume based on the holiday Seeger formula?
Okay, so I'm an adult physician, so we don't use the holiday
Holiday
Sager
Sager.
formula. And then it again is my previous answer. It's about maintenance, and maintenance, think twice, I would say. But I suppose when you're talking about children, small infants, when you want to give maintenance, I suppose that they have no other fluid intake. But then the recommendation would be, and I think pediatricians do, check what any other source of fluid the child is already getting, and take that off of the remainder that you would like to give as maintenance. So I guess giving 2/3, yeah, it seems reasonable because it takes into account that there are other sources of fluid intake.
So apart from the concepts mentioned, there are certain specific clinical situations which would desire, which would demand that the fluid be tailored. So one such question is from Dr. Manjunath. Dr. Jayashree, what is the type of fluid choice in a child with severe gastroenteritis with nephrotic syndrome?
I think that's a little bit of a question that is would obviously not have a straight answer. So, so the situation that in a nephrotic syndrome, we have a state where there is low protein and there is intravascular hypovolemia. And then over and above, this child develops acute diarrhea. So the child is going to have dehydration, which is because of actual volume loss. So hypovolemia is going to be significant. So in such a child, the initial resuscitation would be similar to what you would do for any other child, a non-nephrotic child, to put it. But the problem would be that at some point, one has to see what the albumin is, because the crystalloids, whatever we give as part of correction for diarrhea, is possibly will not be retained in the circulation for a longer time because the child has severe hypoproteinemia secondary to the nephrotic state. But the initial resuscitation has to go on like what you would do for any other acute gastroenteritis. And what WHO recommends for low middle income countries for diarrhea dehydration correction is a lactated Ringer's or Ringer's lactate or Hartmann solution. That's the WHO recommendation. So generally we follow the WHO guidelines for treating dehydration in patients with acute gastroenteritis. So I think the same has to be done for a nephrotic child too, to begin with. But at some point, we need to keep an eye on the albumin, and possibly a requirement of colloid may come in, possibly much earlier than a non-nephrotic child. So this is probably a broad guideline, like whatever.
Dr. Krishnan, there are two questions. Sorry.
Yeah.
No, it's just weird because I would say it's the only indication left for saline. Because if there is gastrointestinal losses, you would assume the patient having metabolic alkalosis, which you can treat with inducing a metabolic acidosis by the saline.
But Professor MALBRAIN, I think it was lower GI losses in a gastroenteritis trial.
Okay.
Yeah.
Okay.
So that would cause more of acidosis or bicarbonate loss, right?
Okay. Sorry.
Yeah, Dr. Manu, there are two questions about the concept of balanced hypotonic solution and how much sodium in this solution.
I'm muted. Yeah. So the sodium should be to cover the daily needs. So it should be 1 to 1.5 millimoles of sodium per kilogram. So in total, let's say for a 80 kilo person, you should deliver about 60 millimoles of sodium. So I think this would be around 0.4 something, like not 0.9 like you have in saline, but 0.4. So it would contain maybe around 42 to 50 of sodium, which is in 1 liter. And for an average person, you would need 1.5, 2 liters a day to cover the daily needs, so that you get the daily needs of sodium. And it also similar amount of potassium. And then it also contains either a buffer like acetate, malate, gluconate, whatever you would like to have less chloride and have an increase in SID. So those are the hypotonic balance solutions that we have in Belgium readily available, which is called Glucium. But I think worldwide there is one which is called Maintalite. I never used it, and I don't know exactly what is the composition. But if we ask ChatGPT or we Google it, we will readily know what is the composition.
There is a question, what's the best IV fluid to use with when child develops hyperchloremia while on dextrose saline maintenance?
Can I pass that on to a pediatrician?
Doctor,
I think you will be the better person to give an answer for this. You're the expert. Please go ahead, Dr. Manu. So, I mean,
If there is an issue of hyperchloremia,
Chloremia.
I don't think we can continue giving saline, which contains too much chloride. So any other solution not containing so much chloride would be better.
so that would be a balanced solution, right?
Yes, yes. So
Dr. Preeta, come. Yeah.
the strong iron difference of 26 or above.
Okay. Similarly, for septic shock, Dr. Preeta Kumar would like to know the type of fluid and amount that we have to use. Dr. Jayashree.
For septic shock, what is recommended by the surviving sepsis guidelines is that for resuscitation, you would use 10 to 20 ml. So the division there is if the patient is hypotensive and we have facilities for intensive care, advanced intensive care facilities with monitoring facilities, then you would go 10 to 20 ml per kilo of crystalloid solution. So what is readily available is normal saline. And in places where you don't have facilities for intensive care, then the volume has to be lower, that is about 10 ml per kilo. And then it has, then you monitor the patient subsequently, depending on the need and fluid responsiveness, whether you can repeat the bolus. So the choice or the type of fluid would be, it has to be an isotonic crystalloid when you are giving for resuscitation. The choice would be between normal saline or a balanced crystalloid.
Right. I think the doctor would like Dr. MALBRAIN also to give an answer to this, to know what he does in his unit on a day-to-day basis in the case of septic shock, I suppose.
Okay, septic shock and burn sepsis is a very nice example. So we will start on day 1 with some fluids to cover the daily needs of glucose and electrolytes whatsoever. We will add on top of that, as resuscitation is plasmalyte. So on day 1, you can have a positive fluid balance. But we will only administer fluids based on hemodynamic monitoring. So in those patients, so we're talking about septic shock, they will have transpulmonary thermodilution. So we have calibrated and continuous cardiac output. We have the functional hemodynamics, like the pulse pressure variation, stroke volume variation. You have the lung water. And we do this in combination with a passive leg raising test. I don't know whether you can do it in a very small infant if it's moving, but if it's asleep, probably you can do something like a passive leg raise test or an anti-expiratory occlusion test. So always assess the fluid responsiveness. Once you're sure that volemia is low, patient is fluid responsive, then of course only give fluids when needed. So there should be some signs of tissue hypoperfusion, shock, either a base deficit that is low, or a lactate that is increased, or capillary refill time, or these kind of indices that you can use. And then we may give boluses. Could be 4 ml per kg given in 10 minutes. And you always reassess before and after. So after giving the fluids, you check what is the fluid status, what is the fluid responsiveness, and then you kind of titrate, but always looking at the safety limits, which for me is abdominal hypertension, is oxygenation, lung water, cardiac ultrasound, looking at signs of congestion, B lines in the lungs. So it's kind of, yeah, dynamic, holistic approach in order to avoid causing harm, and as soon as possible to restore the circulating volume. And if it's sepsis, of course, you need to treat the underlying problem. So source control is imperative. If it's an abdominal perforated viscous, or a sepsis, or an abscess, source control, antibiotics, and then the fluid resuscitation, as I mentioned. So with the balanced crystals, plasma-light, mainly plasma-light. In burn patients, we will also add after 6-8 hours, based on urine albumin creatinine ratio, albumin hypertonic in continuous infusion, titrated to plasma albumin levels up to 30 grams per liter. So it's a bit similar to the Albio study in severe sepsis, septic shock.
Now, after having listened to all the talk about resuscitation fluid, maintenance fluid, still there are some questions which, once and for all, Dr. Jayashree, I would like you to answer. Most of the pediatricians admit cases in the wards or on the floor. We have discussed about the critically ill ones. So what are the maintenance fluids in those children is the question, especially from Dr. Pankaj.
I think for non-critically ill patients, children admitted in wards or post-operative patients, I think the debate is quite, I mean, it is settled now. We don't use hypotonic fluids like what we used to use few decades back. What we used to call as isolite P, which had, I think, normality of 0.18, N by 5 is what we used to call. So for maintenance fluid, what is recommended, especially non-critically ill patients, I think again, Dr. MALBRAIN can correct me. What is recommended is the isotonic. But as I said, even in our unit, once the patient recovers, we go more for half normal saline rather than normal saline, along with 5% dextrose. The 5% dextrose needs to be there in the maintenance fluid. And the volume is usually calculated by the Holiday-Segar formula in children. And we know that Holiday-Segar generally tends to overestimate the fluid needs in a hospitalized patient. And that's probably one of the reasons why there was quite a bit of hospital-acquired hyponatremia in patients, especially in those who are not very critically ill. So therefore, whether we need to restrict the fluid, give 2/3 maintenance or give half maintenance, that is based on the daily monitoring of electrolytes and the intake and output of the patient. But as Dr. MALBRAIN also emphasized, I think it's important that we start oral or enteral feeds as fast as possible, even in children. I think this is the most important step. Once they are in wards and they are not critically ill and their fluid needs are, I mean, the acute needs are gone, one should immediately try to use the gut, use the enteral mode to feed them or to give fluids orally rather than continuing with IV fluids. So I think we calculate by the Holiday-Segar, but we generally tend to restrict because Holiday-Segar overestimates the fluid needs in a hospitalized child. And hospital-acquired hyponatremia is quite common because of multifactorial reasons. And therefore, the fluid which is recommended for maintenance in pediatrics is generally isotonic. But in many centers, including ours, we tend to use the half normal saline with dextrose as the maintenance. I hope, Dr. MALBRAIN can correct me if there is something which is otherwise here.
No, I fully agree. There is this difference between adults and children. So with respect to the tonicity of maintenance, but that we fully understand. I think in a child is more delicate, maybe more rapidly over over resuscitated hypervolemic or hypovolemic than in an adult where it's less difficult. I saw an interesting question. Can fluids be given rectally? Yes, of course, you can give fluids rectally. I think mostly the water will be reabsorbed, but not so the sodium or other things. But a better route may be orally or post-pyloric. There has been a study of French that was presented during an IFAD meeting where they did oral resuscitation in patients with sepsis. But the thing is, of course, if you're really profoundly septic with need of vasopressus and mesenteric hypoperfusion, I'm not sure about the reabsorption rate of oral fluid. Also in edematous patients, when there is bowel edema, there is less motility. I'm not so sure about absorption there. But from a theoretical point of view, yes, you could do. And if there is no other way, please go ahead, I would say. And then I saw a question on de-resuscitation. Is it okay to
Yes,
take
yes,
that
we'll
from
come.
Yes, please go ahead.
Javed Ismail? So the question is about albumin. I'm a fan of albumin for the fact that it stays intravascular much longer than any other fluid, so about 4-6 hours. And the hypertonic albumin allows you to create some fluid shifts. And there has been some studies by Robert Hahn showing that after albumin 20%, 30 minutes later, you see fluid shifts from the interstitium to the intravascular space. So yes, we do give albumin hypertonic. We give a bolus, 200 cc, and then we titrate up to serum levels of 30 grams. If albumin levels are normal, don't give albumin. So only when there is hypoalbuminemia.
One point I would like, sorry to interrupt. When we have not possible to have all this intraosseous route is the most accessible, the best, it acts better than the veins. Of course, if you have Jamshidi, the Iranian hematologist, first invented this needle, or you can use any needle, even LP needles we have used in India. You can give all the drugs also to the intraosseous. It acts as I have used it in, of course, very sick patients, just as a last resort.
Absolutely agree. Yeah.
Why not subcutaneously? If there is any contraindication,
No, but it goes slowly. So
but it's better than nothing. If there is no collapse, then
yeah, then maybe rectal is faster. I don't know.
Okay, you just mentioned regarding compartment syndrome when there is overload, fluid overload, abdominal compartment syndrome, and the first patient you present. And
Yep.
as being a surgeon, you know, there are a lot of studies regarding anastomotic leak when there is an overloading in intestinal anastomosis or in hypospadias, you know, a lot of fistulas because of the intraoperative overload of the patient.
Yeah. Fully agree. Yeah. And I think we don't pay enough attention to fluid accumulation in the perioperative period, postoperative period, as well as abdominal hypertension. We don't measure bladder pressure, and I think we should. We should to identify patients at risk. It may also be a sign of poor source control, so that there was something wrong with the surgery and that you need to have a second look. And all the things you mentioned, like reintervention, fistula, anastomotic leak, wound dehiscence, wound infection, it's all related to fluid accumulation and abdominal hypertension. Also very important, and maybe in children with large hernias, ventral hernias, hernia repair, there also, and for some reason, this is what I remember from my father when he was treating neonates, is that they all develop third space ascites.
Yeah.
A lot of really the puffy children with pitting edema, pulmonary edema, and ascites. Yeah. So a child is not a small adult.
Small adult.
No.
Dr. Jayashree, there's a question about the maximum weight one can apply while using holiday saga formula. For example, 11-year-old comes with an 80 kg weight. So would you still apply it, and what is the upper limit of the IV fluid?
That's a good question, and I haven't thought from that particular angle, so I may not be able to answer that. I need to check that. Yeah. So,
And there is
so
another
I,
question. Yeah, sure, doctor.
no, I
What was
think I'll
question,
have to
Dr.
look that up. Yeah.
Dr. Kalpana, would you please repeat the question?
The
Maybe
question
Saurabh
is,
can help answering that. Yeah.
what is the maximum weight one can apply by using holiday sagar formula? Example, say for example, 11-year-old but weighs 80 kilograms. So what is the maximum IV fluid maintenance one can give? I suppose
American
above a
Academy
certain level,
guideline,
we
I mean,
do.
21 years is a pediatric adolescent. Is saying in children, if they are suppose overweight, you calculate on the ideal weight. The age limit, they don't go. Ideal weight should be calculated even up to 21 years pediatric adolescent. So ideal weight is calculated for 21 years, they take as a
Also, by then,
Or
I think
maybe the fluid should be as per the adult requirement.
adult
I know,
weight, that's what.
Uh,
Beyond
ideal weight or adult
60
requirement.
kilos, it should be do it according to the adult requirement. There's another question specifically with children, best fluid resuscitation schedule in children with malnutrition. I suppose any particular problem we anticipate if a child is severely malnourished.
Yes, so severely malnourished children, they can't handle fluid very well. So they can land up with all the problems of fluid overload and organ dysfunction. They have a high risk because of their poor handling of fluid. So therefore, during resuscitation, we have to be far slower as compared to a normal nutrition child. The volume as well as the rate of fluid during resuscitation as well as rehydration has to be slower. And the normality of sodium in the fluid, especially after you have finished resuscitation, let's say for rehydration or for maintenance, has to be maybe again half normal saline or N/2, what we call, because again they have problems handling a lot of sodium. So I think the rate, the volume, and the sodium content, these are the three things. Severely malnourished, or what we call as severe acute malnutrition, or SAM children, they have difficulties in handling. And we must give dextrose during maintenance because they have high incidence of hypoglycemia. So I think these are 4 or 5 important points to keep in mind when we treat children with malnutrition.
And probably the same as you see with adults, the risk of refeeding syndrome with the electrolytes and the phosphate is probably similar.
Yeah, so they do have a lot of problems with refeeding, or what we call as the nutritional recovery. So phosphate monitoring is important in them.
Dr. Javed is asking if he comes across a clinically fluid overloaded child with NSARCA, but intravascular hypovolemia is seen on ultrasound, IVC is collapsed. How do we treat?
Yeah, there's a bit what I mentioned about the Vexus score. So you can have a grading of venous congestion. So you look, you start with the IVC, and then you go for the the portal vein, the hepatic vein, and the renal vein. But normally, if you look at the IVC and when it's collapsing, you don't suspect that there would be venous congestion. But the study I showed you is that it's not true. You can have venous congestion at other parts, even if your patient is intravascularly hypovolemic and fluid responsive. And those are the difficult cases. I think there, if you're hypovolemic, maybe if albumin levels are low, you can try to recruit some of the interstitial edema to the intravascular space. Maybe you can play a little bit with the ventilator if the child is on the ventilator. But these are tricky cases, and maybe if there is a need for deresuscitation, then it's best with CVVH and ultrafiltration for your metabolic control, at least, and some low doses of noradrenaline doesn't exclude you from deresuscitation. I would say 0.3 gamma micrograms per kg per minute are allowed if you want to deresuscitate.
And I suppose would hematocrit and blood urea nitrogen levels, these two parameters help?
Very good point. Yeah. I think it's used on chronic dialysis machines. You have the continuous monitoring of the hematocrit to see the hemo concentration, hemodilution to adapt the fluid removal. So yes, very interesting. But then you need to have a close monitoring before and after you do something. You could do it in a weaning trial. So you could have weaning-induced pulmonary edema, and then you can see subtle changes in total protein levels, albumin levels, or hematocrit levels. Yeah, it's a good point. What was the other one? Hematocrit levels?
Blood urea
Urine.
nitrogen.
Yeah. The urea creatinine ratio, if it's above 50 for pre-renal azotemia, is still a valid monitoring tool, as well as urinary indices. And I think that's something we don't look at enough. So urinary sodium to assess the effect of your fluid therapy and to follow up, unless the patient has diuretics that may influence, of course. But if there are no diuretics, urinary electrolytes is a very good monitoring tool. And in our hospital, when I was in Antwerp in the burn unit, the laboratory was able to measure colloid oncotic pressure. It's very cumbersome, and they didn't like to do it, but this gives you some idea of the tonicity and the leak. If it's very low, then this may also be a trigger to give some albumin.
So thank you very much. I think Dr. Diari, you want to ask any question, Dr. Saurabh? Otherwise, we've run through the list of questions
Yes.
asked by the audience. So yeah.
There is the
So
last
it is late,
question.
also midnight. Yes. Any
Just there is
question,
the
Dr.
last
Diari?
question. Yeah, there is the last question. Is there any role of fluoride-free fluid in patients with hyperchloremia?
What fluid would that be?
Chloride-free fluid.
Yeah, but
But
balanced
fluoride-
solutions also have chloride. So chloride-free is only water,
Only water.
mineral water, or dextrose or glucose, which is hypotonic solution. Yeah, I
Fluoride-free or balanced crystalloid Hartmann solution.
I would say that solutions containing less chloride or balanced. And Plasmalite has the largest strong ion difference, so it contains the least chloride.
At least.
I
Thank
will
you.
add the last question.
Yes.
I mean, as Dr. Manu mentioned, initially when they made ORS solution, it was 90 sodium. Then gradually decreases to 60. Then they came to 40. I think IV fluids also is going. Remind me of a quotation say, cured of my disease yesterday. I died of my physician today. So we have to be very careful about fluid after this. I would like to thank Professor MANU for excellent illustrated presentation and discussion. Professor Jayashri from India, now it's midnight almost in India. Dr. Prashant, thank you very much. Dr. Prashant's last day was with us at NMC. He's joining a big center in UK. We congratulate him. We miss him. Dr. Kalpana, Dr. Diari, all viewers. I would like to thank all the, still, I think we had about 700 viewers, maybe more. Tawfiq will give us. And thank you very much all. I'm sure in future we'll have more meetings like this with Professor Manu and Professor Jayashri and Dr. Parshan. Thank you very much and good night.
Thank you.
Professor
Thank
Manu,
you.
if you have
Thanks a
last
lot.
comment
Thank
also,
Dr.
thank you
Saurabh,
very much.
And Dr. Derry and
Thank you very much. Thank
Dr.
you.
Jayashri, Professor Manu. We'll see
Bye-bye.
you.
See you.
All
Bye.
the best. All the best, Dr. Pash. All the
Bye.
best. Bye.
Bye-bye.